think today we are expected to give an introductory class, okay, regarding surgical case presentation. Initially, I thought since you are final years, you can start with presentation of case as such. But the director had requested a small orientation or introductory class, whatever it is. So we'll I'll just initiate that introductory class, one thing. But I also want one of you to present a small case, not a very elaborate one. So because introductory class may not be that big. Okay. So who's the rep? Ashwath, right? Who's the representative of the batch? You can unmute yourself and just respond to me. Am I audible to all? You can post your reply in your chat box if you are not unmuted yourself.
Sir, you're audible, sir.
Okay. Who's the batch rep?
Sir, it's Ashok.
Kishore?
Ashok.
Right. So we'll proceed on. Who will present a small case, for example, a lipoma or something, virtual case? Ashok. What's his name? Ashok.
Sir, hello.
Anup.
Sir, I have a case on indirect.
Okay. You can present it following my introduction. Okay.
Okay, sir. Thank you. Sir.
Perhaps today the class will be a bit lengthy. No problem. So okay. This introductory section was introduced at the last time. I was not aware of it, but still we will make it. Okay. Good morning to everybody. I welcome you to the surgical postings, and a different one from our perspective, because we usually are in contact with each other. We bring a patient, and with the patient in front of us, we usually demonstrate the clinical science and get to exposed to the surgical cases. But the scenario is not such now. Okay, we are facing a different scenario, but we will have to live up to that. Okay, so as surgical students, the purpose of a surgical presentation is very, very important. I would say there are two purposes of you learning to give a good surgical presentation. Okay, the first and foremost purpose of a surgical presentation is to get through your exams. That is very important. You will have to know how to present, make a good impression, and get a pass in your exams. That is one of the aims. The next one is you will have to get yourself oriented towards a surgical case. Getting through exams only is not enough. You also have to see how you approach a surgical case sheet and make a diagnosis and plan how to investigate and treat the patient. So the basic aims of a good surgical presentation by a student in surgical department is to get through the exams and to get oriented to how to approach, diagnose, and proceed with surgical procedure in a given patient, right? With those two goals, you get a patient in your hand. So for that, you will have to write a good surgical case sheet. So I don't know if I have taken an introductory class. Usually for the first clinical year, I usually take a class on initiation or sensitization of the new coming students first clinical year. But anyhow, I will just refresh what if I have taken, you can refresh it. If I haven't taken, you can take it as the first sensitization, right? Okay, so the format, the surgical case sheet will have a few components. The first component is the profile of the patient. So in profile, you will have the name, you will have the age, you will have the gender, you will have the occupation, residence. So each of the details in the profile has got its own importance, right? So the name of the patient is to identify him. The age is very, very important because there are certain diseases which are age related. For example, if you are seeing a lump in the breast, the lump in the breast present in a case of 25, 20 plus girl is much different from a lump present in a lady with 50 plus or 60 plus. So age is very important. Most of the time when the residents or the assistant professors present a case to me, immediately the first question I would pose to them is, what is the age of the patient? Because age is very, very important, because most of the diseases are age dependent. So obviously, the malignancies are occurring in a much elderly age group. So age is important. Name is to identify. Age is important. Gender, gender related diseases are. For example, thyroid diseases by and large are occurring more in the female gender. Okay, the other malignancies, most of them, like lung cancer, and your gastric cancers, all they are got propensity, or they occur more in male gender. So gender is important. Occupation, of course, occupation related diseases are very many. For example, a tea shop worker who is standing all the time preparing tea is more prone for varicose veins. Policemen who are standing continuously in the traffic signals are bound to suffer more from varicose veins. Okay. Other occupation related diseases like pneumoconiosis or lung cancers, they are also occupationally related. That is one thing. Okay. And I would like to add on one thing. Don't use the word coolie in your occupation. So you can tell, so coolie is a derogatory term, you should not use it. Laborer by occupation, or you can specifically tell a teacher by occupation or a driver by occupation, like that. So kindly don't put the word coolie. Okay. So that's a profile, and the residence also is important, because certain diseases are endemic to, or preferably occur in certain areas. For example, the persons living in hilly areas, they have more of thyroid problems, goitis. That is one general thing. So there are certain diseases which are peculiarly occurring in certain parts of the country or state, for that matter. So for example, if you take the country as such, gallbladder stones and gallbladder diseases are very, very common in northern states like Kashmir and related areas, surrounding areas. Cholecystectomy is very, very oftenly done, and gallstones are very common there. If you take the world as such, gastric cancer is very much large in numbers in Japan, like that. There are area-related diseases, so you should mention the residence area also. So that is a profile of the patient. Next component of your surgical case sheet is presenting complaints. So presenting complaint is a problem which makes the patient come to you. The patient may be having many complaints, but among this, one complaint will make the patient come to you at the given point of time. That is a presenting complaints. So the presenting complaint should be in one phrase or sentence only, and you should write the duration. For example, the patient is coming to the hospital with presenting complaints of upper abdominal pain for the past 3 months. That's all. Okay. And occasionally, the presenting complaints may be more than 1, 2 sometimes, because both may be equally disturbing. Like the patient comes to the hospital with complaints of upper abdominal pain for the 3 months and vomiting for the past 1 week. It is possible that sometimes more than one presenting complaints may be there. In that case, the longer complaint will be mentioned first, and the shorter duration complaint will be mentioned next. So presenting illness, okay, that is presenting complaints is the next context. So profile, presenting complaints, then history of present illness is the next component of your presentation. This history of present illness, we will divide into 3 domains. Okay, the first part of your history of present illness will be elaboration of your presenting complaints. For example, in present complaint, pain upper abdomen, if the patient has told, the first aim of history of present illness to elaborately describe the presenting complaints. The next domain would be positive relevant complaints. So the patient is complaining of come with present complaints of pain abdomen. You should ask other related positive complaints like vomiting, hematemesis. If it is present, it is called positive relevant complaints. Okay, then loss of appetite, loss of weight. Okay, then next domain would be negative relevant complaints. In certain systems, certain complaints are bound to occur, but if they are not present, you should mention that next. So it is like the patient does not give history of passing high colored urine or no history of jaundice, or the patient is not having any difficulty in bowel habits. Okay, if it is present, you can put it in the positive relevant complaints. If it is not present, you can put it in the negative relevant complaints. So just imagine and think your history of present illness is the most voluminous part of your presentation. உங்க சர்ஜிக்கல் கேஸை எடுத்துட்டு பார்த்தா எல்லா காம்பனன்ட்லயும் voluminous or the biggest one would be history of present illness, because there are many complaints which has to be positively relevant or negatively relevant. So you divide the history of present illness into first domain, elaboration of the presenting complaint, second domain, positive relevant complaints, next one is negative relevant complaints. If you have this in idea, you won't miss out any of the components which are expected for that particular system which you are presenting, right? So that's the history of present illness. Next one would be past history. So in past history, first one would be to mention any similar complaints were in the past. For example, if the patient is complaining of upper abdominal pain, that is a presenting complaint, you can say there is no past history of similar abdominal pain given by the patient. Past history means before 1 year or sometimes even earlier than that. That is the past history. Relevant or similar to the presenting complaint should be mentioned first in your past history. Then all comorbidities you should mention, because they have a big say on decision making and progress of the disease and the morbidity and mortality of the patient as such. So you should mention history of diabetes mellitus, you should mention history of hypertension, you should mention history of pulmonary tuberculosis or any other major illness. Okay, that should be accommodated in the past history. In addition to that, whether the patient suffered from any other major illness for which any other treatment was given should also be mentioned. That is the past history. Okay, so profile of the patient, presenting complaints, history of present illness, a large one, then past history, then next comes the family history. So family history also is important. So before going on to the past history, I would like to give a few examples. Okay, so the patient is coming with history of right groin swelling, let us take. So the patient gives history of being operated for appendix 6 years ago. If it is there, it is more relevant, it should be recorded. Okay, and if the patient is coming with a lump in the breast, okay, lump in the right breast, 45-year-old, for example, in past history, if the patient has been operated for fibroadenoma when she was 25 years old, then you should give in the past history the patient underwent surgery, probably excision of fibroadenoma when she was 25 years old. All these things should not be left out. Okay, so that's the past history. Family history also very relevant. We know few cases where family history is very much important. For example, see a breast, where a elaborate family history should be obtained and recorded in your case sheet. You should ask the first degree relatives, second degree relatives, and beyond that also any history of cancers in the breast or family history you should ask. There are few other diseases which also run along families, like the medullary cancer of thyroid, for example, and your colon cancers. Okay, familial adenomatous polyposis is there. There are many diseases which run along families, so it is very important to obtain a good family history. So after that, personal history is very, very important. You should ask about the diet habit. You should ask about smoking. You should ask about alcohol consumption. You should ask about tobacco usage in the form of chewing, bitter nut chewing. All these are very, very important. And also extramarital relations should also be mentioned there. So the personal history. Then treatment history. Any other noteworthy treatment has been given for any other illness, you should interrogate the patient and record it in the case sheet. Okay, and if it is positive, sometimes history of allergy to drugs may be given. So the history will be completed after this. So the format you should remember: profile, presenting complaints, history of present illness, which is the largest one, which contains of 3 domains: elaboration of presenting complaints, positive relevant complaints, negative relevant complaints. Then you have the past history, you have the family history, you have the personal history, you have the treatment history and allergic. And if the patient happens to be a female patient, you would also be expected to tell about obstetrical and gynecological history in some cases, especially in CFS. You should tell about gynec history and obstetrical history. So that winds up the format of your case sheet up to the history taking. So when the history taking is completely done, you are expected to summarize it in a very crisp and very brief manner. Okay, so you can tell a middle-aged patient coming with a short duration history of upper abdominal pain, not associated with vomiting, no constipation. I would like to examine the gastrointestinal system for a possible gastric malignancy, like that. So summarization at the end of history taking is meant to choose the system which you are going to examine. Okay, there is another summarization which will be given at the end of your examination. The purpose of that summarization is to give a provisional diagnosis. So history mudinja odane kudukura summarization is meant to choose the system. So you should tell in this summarization, I would like to examine the thyroid region for a possible benign pathology or for a possible malignant pathology. I would examine which system you should mention. That is the purpose of summarization at the end of your history taking. Okay. So the whole surgical presentation means there are 3 broader domains. Okay, you should take a good history, make a detailed examination of the patient, and proceed with a good clinical discussion. It will be a good presentation. So you are expected to take a good history, make meticulous clinical examination, and proceed with a healthy clinical discussion. So history patient meticulous examine discussion correct. These are all the phases or parts of your clinical examination. So now we are done with the history taking. We will go to examination. The examination again, the synopsis or the outlay of examination would be general examination, local or systemic examination, examination of lymph nodes is draining lymph nodes, then examination of other systems. So examination in the 4 part of for a surgical patient. Okay, so general examination, local or systemic examination, examination of regional lymph nodes, very, very important, and examination of other systems. Okay. So general examination, the purpose of general examination is not to diagnose the surgical problem in hand mainly. Sometimes it may be changed by your surgical disease, but the purpose of general examination is to assess and evaluate and see the fitness of the patient for the proposed surgical intervention. Okay, so you make up a diagnosis and take up the patient for surgical intervention, and that time the patient should eventually be fit for the surgery, right? So the aspects of the patient which make the patient fit or unfit for surgery are made out by your general examination, right? So you should see the nutrition status, build of the patient, consciousness, orientation, and the general vital signs like pulse, BP, and everything will come in general examination. Do you catch me? The purpose of general examination is to assess and evaluate the fitness of the patient for proposed surgical intervention in the near future. Okay, so the general examination. Then local examination is meant to make the diagnosis. Okay, so generally in a local examination, the parts would be inspection, palpation, percussion, and auscultation. Okay, this is the general one. Certain systems this may not be applicable, like in a varicose vein, the role of percussion and auscultation are not there. Okay, even for a for some other things like squamous cell carcinoma, the percussion and auscultation have no role. So it should also be applied to the systems individually. But generally, local examination will involve inspection, palpation, percussion, and auscultation. In addition to this, according to the some other systems in your hand, you may need to employ some special tests. For example, in hernia, you have got the Siemens test, deep ring occlusion test, ring invagination test. All these are special tests meant for that particular system. For example, if you take varicose veins, you have got many tests like Perthes test, okay, Pratt's test, you've got Hoffman's tests, and many other tests are there. Okay, so those system-wise, you need to employ some other tests which are needed for that particular system. So systemic examination, and the next one would be examination of regional lymph nodes. Very important. This is very specific of a surgical patient. In medicine, you may not come get to present the lymph node most of the time, regional lymph nodes. But in surgery, it is very important, especially when you get a swelling or an ulcer. A swelling occurring in any region for that matter, like a thyroid or a breast, a swelling or ulcer. In that case, the regional lymph nodes or draining lymph nodes should be examined and presented elaborately. Okay. Then examination of other systems. See, the common systems which can be affected by your present disease, like cardiovascular system, respiratory system, abdomen, central nervous system, skeletal system. All these things should be examined and presented. So that's the examination will be complete by this. So you completed the history before, made a summarization to choose the system which you are going to examine. Now you have completed your examination and summarized at this level to make a provisional diagnosis. For example, your summarization at the end of an examination of a thyroid swelling would be like this. So a middle-aged lady coming with the history of recent onset of swelling in the anterior aspect of the neck in the region of the thyroid, not associated with any difficulty in swallowing or pressure symptoms, not having any features of hypo or hyperfunction, and not showing any signs of malignancy. I would like to make the diagnosis of solitary nodule of the thyroid, which is non-toxic, non-malignant. So this would be the provisional diagnosis. So non-toxic, non-malignant, solitary nodule involving the right lobe of thyroid. Your summarization should be like this. Okay. So you make a provisional diagnosis now. The examiner will next ask you, okay, this is your diagnosis. How did you arrive at this diagnosis? You will have to validate it or reason out and give your diagnosis correctly. If it is agreed upon, the examiner will ask you, what do you want to do for the patient? Or he may ask you, how will you manage the patient? Then you should say, I would like to investigate the patient. Kindly do not jump into it. I said I will do right hemithyroidectomy. It is not proper. Okay. So the two parts of management are to investigate the patient and to give treatment. So you should tell, I would like to investigate the patient. Right. So what investigations you will do? Here also there are general basic laboratory investigations which are again meant to make the patient fit for the surgery evaluation. Second one is specific investigations related to the system which you are examining. The purpose is most often to confirm the diagnosis. So general lab basic investigations, then specific investigations to confirm the diagnosis, and the third part will be examinations meant to evaluate the extent of the disease or to rule out metastatic disease. That is the third part of your investigations. Okay, so you should know what are all the investigations for that particular system which will help you to confirm the diagnosis, and also the other investigations which will rule out distant disease. The disease has spread beyond its domains or its region and involving the other areas. So that investigations. So after the investigations, you will offer a final diagnosis, and after final diagnosis, you will tell the treatment. Okay. So the treatment most often will be surgery. You are expected to know 5 components of surgery. For any surgery, there are, to take up the patient for surgery, there are 5 areas which you should cover. I always tell my students to remember the 5 Roman letters. Okay, for the question, if you are asked how will you do the surgery, standardly you tell 5 things. Okay, first one is get the patient anesthetically fit for surgery. Second Roman is to mention the type of anesthesia employed for that surgery. Third one is the position of the patient which you should lay to do the surgery. Fourth one is you should operate under strict aseptic precautions. Fifth one is the incision you want to make. So for example, if you say I want to do a hernioplasty for that patient, my reply should be like this. I will get the patient anesthetically fit and under spinal anesthesia with the patient in supine position under all aseptic precautions. I will make a right inguinal incision. Okay, this is for a hernioplasty. For other surgeries like a hemithyroidectomy also, you should mention similar 5 components. Only thing is they will vary according to the surgery which you are going to do. Right? So this is a surgery. And after surgery, you will obviously be most of the time asked about complications of surgery, which you should mention. Okay, this is the format. So the purpose of surgical examination, I have told you, to get through your exams, to get oriented towards how to approach a surgical patient. Then a surgical case sheet, how to write, what are components, I have told you. Profile, presenting complaints, history of present illness, which again got 3 components, namely presenting complaints, positive relevant complaints, negative relevant complaints, past history, family history, personal history, treatment history, history of allergy, and obstetrical and gynecological history if needed. Then a summarization to choose the system which you are going to examine. Then you get to examine the patient under 3 aspects: general examination, local or systemic examination, then examination of other systems. After completion, you will do a provisional diagnosis, and After provisional diagnosis, you will investigate the patient under three parts: general examination, local examination, and examination of other systems. Then make a final diagnosis, then offer treatment and discuss. Am I clear? Yes, I have been talking all the while. One of you can talk. Ashok?
Yes, sir. It's clean.
Yes. Before we, this is a synopsis or the outlay of what you are going to do as a surgical student hereafter. You can follow this system and start presenting. I think you would have been aware of it, but small rectifications or corrections you can make based on what I have told you now. Okay? I'll give you a few minutes regarding this introductory class. If you have any questions, you can just post it in the chat box or unmute yourself and come out to me. We'll wait for 3 or 4 minutes. And then who will present a case today?
Sir, Anu, me.
Anu. Okay. You are ready now?
Yes, sir.
So today's class, we will not elaborately discuss about it. There are many classes available in future. So we'll make it short. Meanwhile, I will request all other students kindly post any doubt you have got or any corrections you can make in my presentation. Anything? So 57 students are there, right? Okay. Introduction class or presentation on the okay, Anup. Anup?
Yes, sir. Hello.
Yeah, you got a presentation?
Yes, sir.
Yes, you can start now. Other students are ready? We can observe him present and make some discussion regarding that. From next class onwards, we'll give the topic priorly, okay? What system or what you are going to talk, we will tell. Tomorrow you present such case. You can decide take turns among yourselves to present the topic, okay? We will not leave out any topic. We'll one by one, we will present in each case. All professors will be taking classes on their respective admission days. So, Anup, you can start presenting. Yes.
Sir, Mr. Krishna, 48 years old male, coming from Villivakam.
You are sharing your slide?
1 minute, sir. 1 minute, sir. Sir, is it visible, sir?
Not commit.
Sir, is it visible now, sir?
No.
Screen is visible with PPT.
Sir, I shared my screen, sir.
Okay.
We are able to see, sir, the screen.
Is it?
Yes, sir.
One sec. I will try. It's a PPT, right?
Yes, sir.
It's a word, sir.
Word document.
Word document.
Can you try pinning Anup, sir?
One second. Venkat. Okay, start presenting. I'll
Okay,
see
sir.
that it is. All other students, you are able to see the screen share by Anup?
Yes, sir. If you could zoom a bit, it might be better.
Now?
Yes, it's seen.
Sir, can I start, sir?
Okay, you start.
Mr. Krishna, 48-year-old male coming from Villivakam, who's a construction worker, came to the OP with chief complaints of swelling in the left groin for the past 2 months. History of presenting illness. Patient was apparently normal
So,
before.
one step here.
Yes, sir.
In presenting complaints, the examiners or the professors, faculty, whoever it is, they want that to be mentioned in patient's words. Okay?
Okay, sir.
Only at this level. Presenting complaint la technical terms use பண்றது avoid பண்றது நல்லது. The reason is, see, if you use technical terms, it becomes biased. You are already informed. That is the opinion they take. So, in the present and complaints, you will use patient's words as far as possible. For example, inguinal region சொல்றதுக்கு பதிலா groin சொல்லலாம். Okay?
Okay.
ஸோ ஆன்டீரியர் ஆஸ்பெக்ட் ஆஃப் நெக்னு பேஷண்ட்டுக்கு தெரியுமா? தெரியாது. அவன் என்ன சொல்லுவான்? கழுத்துக்கு முன்னாடின்னு சொல்லுவான், ஃப்ரண்ட் ஆஃப் த நெக். ஸோ ப்ரெசென்டிங் கம்ப்ளைண்ட், ஸ்வெல்லிங் இன் ஃப்ரண்ட் ஆஃப் த நெக், ஸ்வெல்லிங் இன் த groin, ஸ்வெல்லிங் இன் த ஷோல்டர், ரைட் ஷோல்டர். நீ சொன்னா ஸ்கேப்புலர் ஏரியான்னு சொல்லுவோம், லைக் தட். ஓகே, ஸோ ட்ரை டு நாட் யூஸ் டெக்னிக்கல் டேர்ம்ஸ் இன் presenting complaints. From next phase onwards, you can start using it, no problem. Yes. Okay. History of present illness, yes.
Patient was apparently normal before 2 months, after which he noticed a swelling in the left groin, which was insidious in onset. It was initially
now you
small.
can put inguinal region, okay, left inguinal region.
Okay.
Okay.
Okay, sir. It was insidious in onset. It was initially small and gradually increased in size and attained the present size. The swelling started in the inguinal region and it extended into the scrotum.
Very good.
It was aggravated on coughing and standing. It disappeared on lying down or reducible manually.
Okay.
So
one thing is you should use the word spontaneously or not. Okay. What is the significance, Anup?
Sir, in direct hernia it will go spontaneous, sir.
Exactly. So இதுல வந்து நீ ஸ்ட்ராங்கா இருந்தீனா, once you say it regresses spontaneously, use that word, the examiner will immediately know that you are aware of the importance of direct hernia. Okay. If you don't use the word spontaneously, the examiner may not have that positive idea about you. Okay. So certain terminologies, things we should cleverly use to create a good impression with the examiner and your seniors as well. Okay, right.
Okay, sir.
So the swelling is aggravated on coughing and hard work, relieved by standing, and relieved by lying down spontaneously, and sometimes needs manual reduction. Okay, right.
Okay, sir.
Next, yes.
It was associated with pain over the swelling, but intermittent, dragging in nature for the past 20 days.
Okay.
It was precipitated on doing work and is relieved by rest, and it's not radiating.
Okay, very good.
And there's no history of trauma.
What is you said the nature of the pain is radiating, right?
Yes, sir.
And it is dragging in nature.
Yes, sir.
What is the reason for dragging nature of pain in the hernia?
Sir, because due to traction of the mesentery, sir.
Good. So there are 3 types of pain possible in a hernia. Okay.
Okay.
First one is what you have mentioned. A dragging pain is occurring in a uncomplicated hernia due to pull on the mesentery. Okay. The contents are obviously, there are only 2. One is the omentum, next is the bowel. Both are having their own mesentery-like thing. Okay. So when they descend down, herniate, they cause a traction on the mesentery. So the dragging pain is to pull on the mesentery. Indirectly, dragging the splanchnic nerves in the retroperitoneum. That is the reason for dragging pain. What is the other pain possible?
It's a spasmodic, sir, in obstruction hernia, obstructive type of hernia.
In obstructed hernia, the bowel makes peristalsis frequently against a non-yielding area. Okay, it goes and goes. So that is spasmodic pain in case of obstructed hernia. What is the other type of Pain.
Sir, in inflammatory type, some pricking type of pain.
Yes, burning or
Burning or
pricking
pricking.
pain in a complicated hernia, namely when the patient and the hernia goes in for strangulation.
Okay. Sir.
Strangulation, eye inflammation, nalla evident vandiruchuna, you will have burning pain. Okay. Dragging pain due to what? Spasmodic pain due to what? And burning or pricking pain due to what? There are 3 types of pains possible in a hernia. You should understand. Okay. Next.
There's no history of trauma, no history
Yes.
of chronic cough, no
Okay.
history of constipation, no history of increased frequency, urgency, or difficulty in micturition, no history of abdominal distension, and
Yes.
no history of vomiting, colicky pain, and no history of sudden increase in size of hernia.
Very good. You have mentioned all that right, but the vomiting should be told first. புரியுதா?
Okay.
Swelling சொன்னீங்க, pain சொன்னீங்க, உடனே next day vomiting வரணும், because the earliest sign of an obstructed hernia is vomiting.
Yes, sir.
Right? Vomiting, அதுக்கப்புறம் constipation, அதுக்கப்புறம் urinary symptoms, other things will follow. Vomiting is one of the very, very important symptomatology of hernia, which is a hallmark of onset of complication. Vomiting should be told first. Okay.
Okay. Okay.
So, right.
Sir, past history, sir.
Yes.
No history of similar complaints in the past. Not
Yes.
diabetic, hypertension, tuberculosis, asthma, or epilepsy.
Good.
No history of previous surgery or hospitalization. No
Okay.
history of blood transfusion. No history of drug allergy.
What is the side of hernia and the swelling in this patient?
Left side, sir. Left side.
Left side. If it is the right side, you should ask about history of
Appendicectomy.
appendicectomy. Yes. How it what is the importance of appendicectomy in a right-sided inguinal hernia?
Sir, while operating, will damage the ilioinguinal nerve, sir. Maybe
Yes.
chances for damage. So it's required for the strengthening of the canal, sir, inguinal canal. So
the injury to
ilioinguinal
nerve results in lower abdominal muscle wall weakness. That is the next step. Once the nerve is injured, weakness of muscles ensues. Okay. So that will lead to herniation. Okay. What is the type of hernia you get following appendectomy?
Sir, Emiland hernia. Emiland, sir. That other name.
No. Common type of 2 hernias, what are they?
Direct and indirect.
Yes. Following appendectomy, what hernia is commonly occurring? Is it direct or indirect?
Sir,
Direct.
sir. Direct.
Yes, direct. So the hernia following an appendectomy operation due to weakness of muscles is most often direct inguinal hernia. Okay.
Okay.
The direct inguinal hernia passes through what anatomical triangle?
Hasselbalch's triangle, sir.
Hasselbalch. Very good. So past history la right-sided inguinal hernia irundhuna appendectomy history is very, very contributory, and the reason behind that you should tell. Okay. Right. Yes.
Sir, treatment history.
Suppose the patient gives history of tuberculosis. How is it relevant in this case?
So chronic
Past
cough
history.
can lead to chronic
Yes.
cough.
So
Increase
a
abdominal
tuberculosis patient can have a destroyed lung, okay, leading on to chronic obstructive problem, which will result in frequent cough, increased intra-abdominal pressure, herniation. That is a run of events. Okay, va? Tuberculosis, destroyed lung, chronic obstructive pulmonary disease, frequent cough, increased abdominal pressure, herniation. So it is an etiological factor, tuberculosis. Okay. Right.
sir.
Next is Sripa.
Treatment history. Not taken any treatment for the current condition, and it's
Yes.
not on any other medication.
Yes.
So personal history. Patient is on mixed diet, does not consume alcohol, is a smoker for the past 10 years and consumes 1 pack per day. Its bowel and bladder habits are normal. Normal sleep pattern.
Okay. What is the implication of smoking on hernia?
Sir, it can cause connective tissue damage in the connective tissue
Yes.
damage.
Number 1, chronic smoking can lead to connective tissue weakening. Number 1. Anything else?
Sir, poor healing, sir. Poor healing after
Wound
surgery.
healing is very bad. Etiologically, a smoker coughs very much.
Ah,
So it is an etiological factor. காஃப் வழியாகவும் இன்ட்ரா அப்டாமினல் ப்ரெஷர் ஆகி ஹெர்னியா வரும், டிஷ்யூ வீக்கனிங்காலையும் ஹெர்னியா வரும். ஒன்ஸ் வந்துச்சு ஆப்ரேட் பண்ணோம்னா ஸ்மோக் பண்ணவங்களுக்கு ஹீலிங் வில் பி வெரி லெஸ். And post-operatively, a smoker, if he coughs, recurrence will be there. All these negative factors are there. Okay? You should remember. Etiologically, 2 factors: tissue weakening and chronic cough. And peroperatively and post-operatively, these things. Healing is very bad. Recurrence is possible. And post-operatively, if he coughs, the healing will be delayed. Okay? Right.
Okay, sir. Family history, no history of similar complaints in the family, no history of connective tissue disorder in family.
Very good.
So, summary, sir.
Yes.
Mr. Krishna, 40-year-old patient, presented with unilateral reducible swelling in the left groin since 2 months, which was aggravated on coughing and straining. There is no history suggestive of strangulation or obstruction of the hernia. So, with this complaint, I would like to examine the inguinoscrotal regions.
Check for possible hernia. Okay. Right.
Okay, sir.
Come to examination now.
Sir, the patient was conscious, oriented, cooperative, comfortable at rest, afebrile, moderately built and moderately nourished, no
Yes.
pallor, no icterus, no cyanosis, clubbing, no pedal edema, no significant generalized lymphadenopathy. Vitals pulse rate was 81 per minute, regular, normal volume, no specific character. It was felt in all the peripheral pulses, and no radio-radial delay or no radiofemoral delay. Respiratory rate was 17 per minute. It was regular and it was abdominal thoracic. Blood pressure was 130/90 mmHg measured in right upper limb sitting posture. Temperature was 37.4 degrees Celsius.
Okay. So this is the general examination. As I told you, this is meant to assess and evaluate the patient for future surgical intervention. Okay. But if the examiner feels so, he may intervene you at any part of this and ask about hemoglobin, Kakla. It's more commonly in the case of CS stomach. They will ask you more about hemoglobin, your real liver function tests, all those things they may ask. So you should be prepared for everything. Okay.
Okay, sir.
Right.
Okay, sir.
Local
So,
exam.
examination. On inspection, after consent, the patient was exposed from umbilicus to mid-thigh, and the patient was examined in standing position. The scene, a single swelling is seen in the left inguinal region. It was 5x5 approximate size and pyriform in shape. It was situated about 7 centimeters from
Can
the
a
anterior.
pyriform be 5x5? 5x5 means a hemispherical swelling.
Okay.
It's a circular swelling, hemispherical. Yes, you mean pear-shaped or pyriform? How can it be 5x5?
Yes. Sorry, sir.
You just make some.
Yes.
You should give it correctly. Okay. You can
Okay.
say 5x3.
Okay.
So it is like pear-shaped. Okay.
Okay.
Right.
It was situated about 7 centimeters from anterior superior iliac spine, and it was just above the root of the scrotum.
Good.
The surface is smooth, well-defined margins. Skin over the swelling is normal, and visible cough impulse is present.
Very good.
And no visible peristalsis or scars or sinuses or dilated veins.
Okay. If there is peristalsis, what is your interpretation?
Sir, maybe the thin individuals, we can see the movement of the bubbles, sir. In thin individuals, the skin.
If peristalsis is visible, then it is meaning that the intestines are the content or enterocyte.
Yes, sir.
It means that it is enterocyte, you should tell. Okay.
Yes, sir. Okay, sir.
Yes.
Can I proceed, sir?
Proceed.
External genitalia, the penis is in midline. Urethral meatus normal. Scrotum appears normal. Root is present. Testis is seen separately. Can be felt separately.
Okay.
Yes.
So here I want to mention one thing. If you are examining a inguinoscrotal swelling, right?
Okay, sir.
A incomplete hernia up to the mid-scrotal level or a complete hernia for that matter, you should always tell if there is a hernial component in the scrotum, you should mention whether the testis is seen separately or not, you should mention. Okay?
Okay, sir. Okay.
You have told that the swelling stops at the root of the scrotum, so it may not be needed in this case.
Okay.
But if you are telling the extent is up to the mid scrotum or bottom of the scrotum, then you should tell whether the testis is seen separately or not. Why is it
Okay, sir.
important, Anup?
Sir, in hydrocele, the testis can't be seen separately, man, sir.
Very good. It is, where in what other condition?
And in complete hernia also, sir, the testis is displaced backwards, sir. The
Yeah,
hernia,
exactly. Yes,
okay,
exactly. This is very important. The testis will not be seen separately in a complete hernia, where the fundus of the, fundus of the sac, hernial sac, comes up to the bottom of the scrotum and displaces the testis posteriorly. So it will not be visible separately. Okay. So the point I want to stress here is when you are presenting a inguinoscrotal swelling, you should mention this. You should not leave this out. Whether the testis is seen separately or not, you should mention in your presentation. Okay? Right.
Okay.
Next.
palpation.
Hmm.
No, not warm, not tender. A single swelling of size 5 into 3, sir. I'll change it. The left
Good.
groin was piriform in shape, was confirmed. And the extent was also confirmed by palpation. The surface and the skin over the swelling was normal. Surface is smooth. And it was soft and elastic in consistency, sir. The swelling.
Very good. Very good.
And propulsive expansive cough impulse felt.
Very good.
Then the swelling is reduced manually with initial difficulty, and it reduces the gurgling sound.
So it reduces with the gurgle, right?
Yes, sir.
Okay. What are the other consistencies possible in a hernia?
Sir, granular consistency seen in omental. If omentum is the content of the hernia, sir.
Yes. Any other consistency?
Doughy in early.
Doughy consistency. So
In early omental.
bowel as contents, it is elastic and soft and elastic.
Yes.
If omentum is the content, early part it will be doughy, right?
Yes, sir.
So a long-standing omentocele, the omentum will become a bit inflamed, and you can see the granular swelling. Omentum இப்பதான் கொஞ்ச நாளா தான் வந்திருந்ததுன்னா it will be doughy. இப்படி மாவு மாதிரி இருக்கும். கையை வச்சா டவ் வச்சனா கை சப்பாத்தி மாவுல கை வச்சா அப்படி இருக்கும் லைட்டா அந்த மாதிரி இருக்கும். Okay.
Okay. Okay.
If it has stayed on there for some time, the incarcerated omentum will develop some coarse nature and will become inflamed and will be palpable as a granular thing. Okay. So early omentum, doughy feeling. Delayed omentum, granular feeling. Intestine, soft and elastic. Okay. Right.
Okay.
Reduction with gurgle is suggestive of
Just enterocele, sir.
enterocele. Okay. And on reduction, is there anything else observable? Nature of reduction, which can differentiate a omentocele and enterocele?
In omentum, it will be initially easy to push the bubbles, sir. The later
Yes.
part will be difficult, sir.
Reason?
In omentum. Because it is adherent to the sac, sir.
The omentum is adherent to the
distal
fundus of the sac. Okay, so early it will be easily going. Last one will be difficult because of additions of the omentum to the fundus of the sac. Okay, right.
Okay.
Next. The other ways, omentocele, enterocele.
Sir, since the content is air, sir, first we have to pass the air through the. Then only we'll reduce the intestine, sir.
Okay.
So
So, enterocele, earlier part will be difficult, later part will be easy. The reason is number two. Two reasons are there. One is overcrowding of loops. Omentum அவ்வளவு போக முடியாது, but loops of intestine go one by one, they can go and coils up. So, first reason is overcrowding of intestines will make initial part difficult. Second one is entrapped air in the intestine, which will also make the early part difficult. But when you empty the air, the last part will come easily. So the crowded things, a few of them are reduced into the peritoneal cavity, the rest will come easily. Okay. So early part is difficult, late part is easy in a enterocele. The reason I have told you. Yes. Next.
Special test.
Yeah.
Deep ring occlusion test. The swelling does not appear on occlusion. Zeeman technique. Impulse felt at the index finger. Finger invagination test. The finger goes upward, backwards, and laterally, and the impulse was felt at the tip of the little finger.
Very good. How exactly you will do deep ring occlusion test?
Sir, can be standing position or lying down position, sir.
Yes.
Then we have to measure the distance between anterior superior iliac spine and the pubic symphysis.
First, for all these tests, you should tell I will reduce the hernia.
Okay, sir.
All these tests should be done after reduction of the hernia only. And if the hernia is irreducible, these tests cannot be done.
Okay,
Occasionally, you may be given a case which is irreducible. In that case, you should tell these tests could not be done because I tried to reduce the hernia is irreducible, you can tell. Okay. So when you present these special tests, you should always tell I will reduce the hernia first. Okay. Okay.
Yes.
Standing or lying down position, you have reduced after reduction of the hernia. What will you do, Pa?
Sir, we have to measure distance between anterior superior iliac spine and pubic symphysis, and we have
Yes.
to take the midpoint of it, sir.
Very
Mid-inguinal point, and we have
Yes.
to take 1.2 centimeter above the mid-inguinal point. That's
Yes.
the location of the deep ring, sir.
Very good.
And if we occlude the deep ring, since indirect hernia comes through the deep ring, sir,
Yes.
well, it won't come, sir.
Yes.
While direct hernia, as it comes directly from the Esselberg's triangle, medially,
Yes.
it will appear
Yes.
as medial. It will come medial.
Very
to
good.
the-
So your wording should be after occlusion of the DRO, the swelling does not appear. Okay, in a case of indirect, it appears on coughing. You occlude and ask the patient to cough. It appears. It is direct. It does not. Your wording should be it appears or not only. You should tell.
Okay, sir.
Okay. It appears through palpable. Na solakudadu.
Okay, sir.
The purpose of DRO test is to observe whether it is appearing after occlusion or does not appear. That is the correct word you should use. Okay.
Okay, sir. Okay,
Right.
sir.
What are the fallacies of DRO test or exceptions when it is not reliable?
Sir, if it's pantaloon type of hernia, both direct and indirect can occur, sir, at the same time.
Very good.
Then the deep inguinal ring, if it's very large, we can't occlude
Yes.
the ring also
Very good.
fully
Very
completely.
good. Two conditions. Pantaloon hernia, where there is another component which may still appear in addition to a indirect component. Next one is very patulous deep ring or very big deep ring. Even if you put your hand, you will be occluding only half. So an indirect hernia will also come out through this. So the fallacies are these two you should remember. Okay.
Okay, sir.
What is the medial boundary of deep ring, Anup?
So medial boundary is
Any important structure is there?
inferior epigastric artery, sir.
Correct. Very good. So the deep ring of medial aspect, you will see the inferior epigastric artery. Okay. Proceed.
So percussion.
So
sir.
invagination test you have told, Siemens you have told is agreed. Okay.
Can I proceed?
Percussion.
Sir? Percussion.
Okay.
Resonant note heard over the swelling.
Okay.
Normal vowel sounds heard.
Resonance implies what?
It's the content of intestine, sir.
Intestine. If enterocyl is there, you will have a resonant note. Otherwise, you will have a dull note.
Dull.
Okay.
Auscultation,
Yes.
normal vowel sounds.
Okay.
Then examination of the right inguinal scrotal region was normal. And
Okay.
examination of regional lymph node not enlarged. No
Okay.
enlargement. Sir. And examination of testis, scrotum, and penis were normal.
Okay.
Other systemic examination.
Hmm.
Abdomen was soft, non-tender, no free fluid, and no organomegaly. On
Hmm.
head tracing test, there's no Malgagny bulge. And
Yes.
there's no divarication of recti.
What is the significance of Malgagny's bulge?
Sir, if it's present means it indicates loss of tone of the abdomen, sir.
What should you do for that?
Sir, we can't do hernia or Raffi for that, sir, because
Yes.
it's already weak, sir, muscle.
So
Can-
the compulsory procedure to be done is a plastic mesh reinforcement. No Raffi should be done for a patient with positive Malgagny's bulge. Okay.
Okay, sir.
I would ask you only one question here.
Okay, sir.
Where is the exact location where you will see the Malgagny's bulge?
Sir, it's above the inguinal region line.
Tell me the quadrant of the abdomen.
Sir, it's
What are the 9 quadrants of the abdomen?
sir, left and right hypogastric, epigastric,
Hypochondriac,
hypochondrium, hypochondrium, sorry.
right hypochondrium, epigastrium, left hypochondrium, then
and left iliac and right iliac,
okay,
lumbar, left lumbar and right lumbar,
okay, umbilical,
and hypogastrium.
So okay, you told 9 quadrants,
Yes.
segments of the abdomen. In which part you will mostly see this small gagnis bulge?
Right and left iliac, sir. It's a bilateral
Iliac.
swelling.
Yes,
So-
it is laterally placed.
Yes.
Why is a small gagni not seen medially or midline?
So don't know, sir.
It's only anatomy.
Rectus abdominis, sir.
Yes,
Because of rectus abdominis, sir.
correct. Can you be more specific?
The rectus sheath. and
Yes.
the
So the
middle-
laterally, the muscles are predominantly not covered by fascia, right? Lower down. Both iliac fossa muscles will be bare without facial cover. Whereas you come on medially, rectus sheath is there. Sheath is a plaster structure which does not allow the muscle to splay. Okay? Small gagnis bulge எல்லாது 5 muscles டைட்டா இல்லாம ஒவ்வொரு ஃபைபரா அப்படி bow ஆகுது, bowing out or splaying out of muscle fibers due to weakness causes the small gagnis bulge. Okay? So it is a bit of anatomical understanding of the abdominal musculature. So inferolaterally, the abdominal muscles are bare of facial cover. They are more muscular in nature, so they get splayed and cause small gagnis bulge. Coming on medially, there is strong facial cover over the muscles, namely, exactly as our student has told before, tight facial cover is there. It will not allow the muscle to splay out or bow out. So there is no small gagnis bulge there. Okay? Right. So any other sign in the midline abdomen which is suggestive of weakness? What is divarication?
Divergent.
Yes.
Ah,
So
sign of
divarication
direction.
also is a sign of weakness. Okay, that is in the middle, but it is not an individual muscle fiber bowing, but collectively the right rectus and left rectus will display as a segment, and middle the linea alba will become very prominent. Okay, so divarication is also a sign of weakness of muscles, though not individual fibers. Right, pa?
Yes.
Okay, come.
Abdominal muscle tone was normal. No hernial
Oh.
orifice, other hernial orifices.
Very good.
No dilated vein scar or sinus.
Yes.
So, respiratory system, normal vesicular breath sound heard and no added sound.
Yes.
Serious S1, S2 heard, no murmur. And CNS, no focal neurological deficit.
Okay.
So, diagnosis, sir. Final diagnosis.
Yes. Yes.
Left-sided, reducible, incomplete, indirect inguinal hernia with bowel as its content without any complications.
Good. Sorry. What is the cardinal feature of all your findings to say that it is a hernia?
Sir, expansile cough reflex, cough
Yes.
impulse.
That is the most important. All students should remember the most important cardinal feature which confirms a hernia is the expansile cough impulse. All others are variable. Okay? Right. Yes, what will you do for the patient?
So first we'll do a routine investigation like complete blood count.
Okay, we will
random
leave
blood-
that. We will leave that.
Specific investigation include USG abdomen and pelvis, sir.
Okay. You need any investigation to confirm the hernia?
No, sir. To rule out other causes, we are using as a USG.
Yes.
Like,
So at this stage, you should understand that hernia is by and large a clinical diagnosis. No investigations are needed to confirm the hernia, but you will do some investigations to see the etiological influences which can cause herniation, right? So one such investigation of the abdomen, right? So investigation பண்ணுவியா அப்படின்னு கேட்டா you say you should use the exact words. Okay, hernia is primarily a clinical diagnosis. No investigations are needed to confirm the diagnosis, but I will do investigations to see the etiological factors which cause hernia, sir. You should tell,
Okay.
right?
Okay.
So, what is the etiological factor you would like to make out? And what?
In elderly male, BPH is a cause, a common cause.
Very good. How will you? What investigation you will do to make out BPH?
So in USG, we can see the post-voidal urine amount, sir.
Post-voidal?
Urine amount left.
Residual urine.
Residue. Oh.
Post-voidal residual urine. How much is significant?
60 to 100 ml, sir.
Very good. Some say 60 ml is also significant. So 60 to 100 ml you can tell. So if the residual urine is more, then the patient is likely to suffer from prostatomegaly. In addition to that, even before doing a post-voidal residual urine, you should measure the volume of the prostate or the weight of the prostate also. You will confirm prostatomegaly first.
Okay.
And then do post-voidal residual urine. Okay? Even before that, they will say prostate is very much enlarged in terms of volume or weight. They can tell. Okay? Right. Any other investigation you want to do? This is one of the etiologies which make any pulmonary etiology can be
X-ray.
Yes.
X-rays.
You should do X-ray. What are the things you can make out in X-ray?
Sir, if with TB we can see cavity lesions, fibrosis.
Yes. Active tuberculosis you can see, or post-tuberculous sequelae you can see. Right? The pulmonary tuberculosis would have healed, but healed with a scar. There will be fibrosis, fibrocaseous remnants. They are called sequelae. Right? So, specific investigation la first ultrasonogram solidno, adla enna papan solidno. Then I will do a X-ray test to see any evidence of bronchitis, COPD, or any post-tuberculous sequelae. Anything is there, I will see, sir. Solidno. Okay?
Yes.
Right. Then.
The treatment.
Yes. What will you do?
So, use left-sided lichen stain tension-free open mesh repair hernioplasty.
Okay.
But you can also go for laparoscopy because hernioplasty also.
That's a choice. Very good. But why do you want to operate on this patient? Why don't you leave him alone?
Sir, maybe the chance of strangulation or obstruction can occur if you leave it, sir.
So here, this is the first, final year posting, you should know how to answer cleverly. For any surgical problem for that matter, what is the indication for surgery? If they ask you, your first indication should be, your word should be to avoid complications. That is the commonest indication we have to operate. Why should a surgeon operate? Because he gets fees? No. See, certain problems, most of the problems, or almost all the problems, if they are left out without being operated, the patient will definitely go in for complications. So your answer would be, why do you want to do surgery for this patient? If they ask you, you should be to avoid future complications due to the disease. Okay.
Okay, sir.
Second indication may be cosmetic in a few individuals. Right? For example, lipoma at the forearm இருக்கு, ஒரு short sleeve போட்டாங்கன்னா உங்களுக்கு அது அசிங்கமா தெரியும். Okay, there is a lipoma at the forehead. It is not nice, and there's a small papilloma here for a girl who is getting married soon. Then you'll have to remove it. That is all. That is cosmetic reason, right?
Yes.
You would have seen people with a big colloid goiter. இவ்வளவு பெருசா இருக்கும். And the colloid goiter usually will not cause complications, but the patient still wants to get it operated for cosmetic reason. So second indication would be cosmetic reason. Third indication will be sometimes the patient will have mechanical hindrance. Okay, so you would have seen patients with a big lipoma at the nape of the neck. Nape of the neck, very lipoma. You have seen many patients develop nape of neck lipoma. And the lipoma will not cause any complications at the earliest. Happily, he can live with the whole of his life with that lipoma in place. But every night when he goes and sleeps, he will see there is an additional pillow here. The pillow which was supposed to be here will be here. He will be constantly hindered. That is called mechanical hindrance. Even a patient with a hydrocele, in addition to the complications anticipated, his immediate problem will be mechanical hindrance. He will put his leg on his two-wheeler or a bicycle. He will feel it is not very convenient. So the large swelling which is causing mechanical hindrance. Okay, va? Same person, when he wears pants and tucks his shirts, he will feel embarrassed. That is again cosmetic and mechanical hindrance. So do you understand, students? The indications for surgery in any surgical patient is only 3. Almost in all the patients, to avoid complications will be the answer. In a few patients, cosmetically implied. And when in very few patients, it may be mechanical hindrance. Okay, Anup?
Yes, sir.
What is the indication? Why do you want to do surgery for the patient in this case?
To avoid complications.
Very good. Now, the examiner can take you, ask you to travel him along with him regarding this complication. That's a big topic. What are the complications? How to manage complications? So, obviously, we will dedicate another class for that. Okay? So, the indication would be to avoid complications, right? So, what I mean is, in the hernia class, one class in the subtopics will be discussed. So, one class will not be enough. Right? Complications பத்தி ஒரு டாபிக் பேசுவோம், சர்ஜரியோட காம்ப்ளிகேஷன்ஸ் பத்தி பண்ணுவோம். சர்ஜரி பண்ணலன்னா, ஸோ இட் நீட்ஸ் மோர் தென் ஃபியூ கிளாஸஸ் டு கம்ப்ளீட் இட் cover it up fully. Now we will see finished up quickly today. Okay. In further classes, individual fields we will talk in detail. Okay. So you will do a right-sided, left-sided, like instance, tension-free herniaplasty, right?
Yes.
Okay, this is tension-free. In what surgery tension occurs, Anup?
Sir, herniorrhaphy, sir.
Very good. So, herniorrhaphy, it is tension because it is non-anatomical approximation of structures, right?
Yes.
So, there is a inguinal ligament here. There is a conjoint tendon here. By nature, there is a gap between that two. Okay? It gets weakened and direct hernia occurs. What happens in herniorrhaphy? That normal anatomical space is shortened and you approximate the structures non-anatomically. That is raphy. Okay?
Okay, sir.
In a tension-free repair, you do not obliterate the normal space. Instead, that space you patch up that space with a mesh, artificial mesh. So that is called tension-free repair. Okay. How will you do surgery for this patient?
So first we have anesthesia fitness, sir. First one.
Good.
Then you have to spinal anesthesia should be given for the patient.
Good.
Then we have to keep the position of the patient in supine position.
Very good.
Under aseptic precautions, we have to
Yes.
give incision, the left inguinal incision.
What?
Left
Yes, it is
inguinal.
I will make a left inguinal incision.
Inguinal incision.
Right?
Yes,
What is the surface marking for inguinal incision?
Sir, medial 2/3 of the line joining the umbilicus and the anterior superior iliac spine, sir.
Umbilicus.
Sorry, not umbilicus. The inguinal ligaments, anterior superior
The
iliac
line-
spine and
Yes, line drawn parallel. Okay. A line drawn above and parallel to the medial 2/3 of the line joining pubic tubercle and anterior superior spine. புரியுதா? So pubic tubercle is here, anterior superior, அது ஒரு line போட்டுருவோம். That is the inguinal ligament. அதுக்கு மேல 1 inch or 3/4 inch above that parallel you should make only 2/3. Okay. So inguinal incision is a line drawn above and parallel to the inguinal ligament in its medial 2/3. Okay, va? Inguinal ligament above and parallel 1/2 inch or 1 centimeter, only 2/3. So you need not go fully lateral. Okay, right. So herniaplasty you are doing. What is the other recent or advanced surgery available for hernia repair? You already told me.
laparoscopy.
Laparoscopy. What are the types of laparoscopic mesh placements available?
Transabdominal preperitoneal repair, sir, and trans extraperitoneal repair.
Total.
Total extraperitoneal.
One is
repair.
transabdominal preperitoneal.
Preperitoneal.
Next one is total extraperitoneal.
Extraperitoneal.
Okay, right.
Okay.
So we will discuss all in detail all about that in future classes. Other professors and chiefs will also be taking classes for you. So this since we have started with an introductory class, I think we'll finish it today. Subsequent classes, which aspect of hernia we haven't covered, we will emphasize and try to catch up with all areas of hernia where all questions will be asked. Okay. Perioperatively, there are some standard questions which will be posed by all examiners. For example, when you operate and enter the inguinal area, how will you identify the sac? How will you identify the neck of the sac? Okay, and all what is the complication of, management of complicated hernia? They will ask differences. All that thing we'll discuss in future classes, right? So, students, if you have any doubt here, you can post it in the chat box. I'll wait for a few minutes. Anup, meanwhile, do you have any doubt?
Sir, one doubt, sir.
Yes.
Sir, in the special test we mentioned, no, sir, all the
Yes.
three. For left-sided hernia, we have to use left hand, sir, for it. If the hernia is in the left.
Which test you want?
Zeman test.
Zeman test.
Yes. Sir.
See, the usage of these fingers should be convenient for you. Usually what I tell you is, you can use like this. You can stand for the right sided, you can stand here and use your finger like this. Okay.
Yes.
This one for saphenous opening, this for the superficial ring, this for the deep ring. Okay.
Okay.
The compulsory usage of index finger, middle finger, little finger is not mandatory. You can use the terms medial most finger, middle of the three fingers, lateral most fingers. You can use any fingers for your convenience. For the left side, you will have to come left and use like this.
Oh, okay.
Okay.
Okay. Okay.
So, from my personal view, what fingers you use is according to your convenience. It doesn't really make a difference.
Okay.
But you stand on the right side and use your convenient fingers. But when you tell the impulse is felt at the lateral most finger, or the impulse is felt at the middle of the three fingers, or you tell the impulse is felt at the medial most finger. Like that you can tell. You should stand on that side and use your convenient fingers. It doesn't really matter which finger you are using, but the terms how you tell is important, right? Okay. So index finger, middle finger, so that you say three fingers are there. The impulse is felt at the lateral most finger. You can tell. That is agreeable. Okay, right.
Okay.
Anything else?
Thank you.
Any other students? Okay. Right. Shall we wind up?
Yes, sir. Sir, next class, what case should we be presenting, sir?
My class or other classes?
Your class, sir.
Next week, huh?
Yes, sir.
I leave it to you. The exam cases are long cases. You should practice and present inguinal hernia, direct, indirect. That is one thing. Okay.
Yes,
You
sir.
should present a locally advanced breast cancer. You should also present and get familiar with CA breast with metastatic status. Two types. Okay, early breast cancer usually will not come for us. Most of the breast cancer will be locally advanced breast cancer. So you will have to present this. In thyroid, you will have a solitary nodule kept as exam case. You will have a multinodular goiter. Mostly we will have in euthyroid state only. Toxic MNG is very rare to come. If one case is available at that time, they may keep it. And in abdomen, you will have to see a GOO case, gastric outlet obstruction. So, இப்போ மறுபடியும் சீஃப்லாம் எடுக்க போறதெல்லாம் என்ன கேஸ் எடுக்கிறாங்கன்னு பாருங்க. In addition to that, we also present varicose veins, hydrocele, short cases, and ulcer, swelling, okay, squamous cell carcinoma, penile CA. These are all possible cases. So, I leave it up to you, but you make sure that you discuss one such cases with each chief. So, you, according to what cases chiefs handle in this 1 week time, you can decide and ask me the previous day or 2 days before. Okay?
Okay. Yes, sir.
Right. So all these systems need to be covered. You want me to discuss which system, you can tell. I'll be ready for that, no problem. It is a demand and meeting, like what you want, we'll do. And make sure that you don't leave out any of the topics. Okay? We'll decide on that 2 days prior to next class. Right?
Yes, sir.
Okay.
Thank you,
Bye.
sir.
Thank you, everybody. Thank you.
Thank you, sir.